Kulkarni for his presentation and in the competition. The title of the paper is Degenerative Spondylolisthesis, When to Fuse and When Not to, a new scoring system to aid decision making. Dr. Arvind Kulkarni.
Dear chairpersons, seniors and my dear friends, the management of degenerative spondylolisthesis is highly controversial. The spine community is split into two extreme polarized positions. Some decompress, many fuse. Why and when? There are no guidelines. There is no algorithm in literature. These two polarized groups are making a big blunder here. It is a big mistake to consider degenerative listhesis as black or white because it comes in shades of gray. Hence, it is not a homogeneous entity. Again, many of us here are not aware of the virtues of minimally invasive spinal decompression, especially when it comes to adequate decompression, achievement of an adequate decompression without rendering the segment unstable. This flawed theory of homogeneity of degenerative listhesis can lead to overgeneralization and oversimplification of a multifaceted, complex pathological entity, subjecting all patients to a relatively longer, a relatively more morbid, and relatively more expensive operation, which is echoed by the sentiments of the editors of Spine. Degenerative listhesis is a diverse condition. Comparing one case of listhesis with another is like comparing oranges and apples. There are various factors which influence decision making, which are enumerated here. So this particular study, which was stretched over 10 years, can be divided into two components. The retrospective component to conceptualize a scoring system to guide treatment plan based on a previously operated cases of degenerative listhesis, and the prospective component was framed to test the validity of this scoring system in a prospective cohort. The scoring system was conceptualized after a retrospective analysis of consecutive patients with degenerative listhesis involving L4, L5 alone who had failed conservative trial between July 2007 and October 2011. These factors were considered. Factors which promoted instability were scored. Again, the antagonistic factors which provided stability. So back pain scored 2, young age scored 1, high activity level scored 1, mobile listhesis scored 1.5 in terms of angulation and 1 in terms of translation. Sagittal facets which promote a slip scored 1 over a defensive coronal facet orientation. Facet effusion, which is a well-known sign of instability, scored 1. Tall discs have a higher propensity to slip, so they scored higher than the collapsed disc, which hardly moves. Again, if it was not conducive or feasible to do a minimal access conservative decompression because of bad anatomy, that scored 1.5. And these individual scores were then totaled to give a final score. Now, the scoring system was then applied to patients with degenerative listhesis from 2011 and 2017, the ones who were operated. And in both the groups, we measured the outcomes in terms of ODI, VAS for back and leg pain, preoperatively and at frequent intervals of time. So coming to the retrospective study, we had 131 patients who were operated for one-level listhesis at L4-5. 41 patients had undergone decompression alone, and 90 patients had undergone fusion. So they all did equally well in terms of ODI, VAS for back and leg. It was interesting that we saw a pattern developing here. The ones who had undergone decompression alone scored less than 6, and the ones who had undergone a fusion scored 6 or more. And when this was applied to the prospective group, we could save 1/4 of the patients from a more bigger, a more expensive and a more morbid surgery. That is, in 52 out of 201 patients, we could just get away with the decompression alone. So they all did well, except 4 patients who needed a fusion procedure later on for progressive instability. So this lady has no back pain. She is elderly. She has a very low demand lifestyle. Her dynamic film shows just a few millimeters of translation. She has a collapsed disc. The facet orientation is a God's gift to her. It will prevent her from slipping. There is no facet effusion. The total score is only 1, my friends. And this is so far away from the benchmark of 6. Why would one fuse this patient? So this patient underwent a minimal access decompression, which were described at various platforms. So this is a pre-op and post-operative images of the patient, adequate central canal and lateral recess decompression with little or minimal collateral damage. Look at this fine looking beautiful scar. She goes home the next day. Why trouble this elderly lady? The diagnosis of degenerative listhesis is made on a lateral X-ray. Does that mean we just take this into purview and shoot screws into L4 and L5 and put the cage in between? No. We are all doctors. We are all mature orthopedic surgeons. We have a holistic view towards our patients. We assess the patient in totality. This patient is elderly, has no back pain, neurogenic claudication alone, hardly moves in flexion extension, very well supported facet joints. This coronal orientation will never slip. It's a God's gift. So her score is just 2. So far away from the benchmark of 6. Why fuse her? Other extreme, this is a patient who has back pain, he's young, he has an active lifestyle, it slips in flexion and extension, a tall disc, facet effusion, he scores 8.5, undergoes a fusion, rightly. So the management of degenerative listhesis, which was clubbed with simple stenosis, was destructive laminectomy. Christmas is nearing. This was infamously called the Christmas tree decompression. Not only the laminae, even the facets, the pars, sometimes even the pedicles, and even the discs were removed in the past. And this obviously led to severe instabilities. That's when Herkowitz came out with his landmark paper, which changed the narrative totally. He advised blanket fusion for all cases with listhesis. Many studies followed, and fusion became the norm. And this was the time the pedicle screws hit the market, and there was a boom in implants. And when market enters science, who can stop it? Again, fusion has its own issues. Again, we all know now that degenerative listhesis is not a homogeneous entity. The current thinking should be to customize treatment for each individual patient. Now, 40% of us in this August hall may be having a slip of 3 millimeters. We are asymptomatic. The natural history of listhesis is that it is inherently stable. They hardly progress greater than 1. They always restabilize. There is poor clinical and radiological correlation. This was a landmark paper which we published last year. This basically shows that when you become old, it is only the intervertebral disc which acts as a stabilizer of your segment. So when you do a laminectomy, don't touch the disc. So there are natural intrinsic stabilizers which support you against a slip. So why, touch the disc? Again, there are a lot of good things written about minimal access decompression now, that it provides excellent results. The progression of a slip is just 2.6% after a surgery, and many of them restabilize, and the need for a second surgery is less than 1%. And I can't talk about the cost, which is almost 10 to 20 times higher in India and about 500 times higher in the US when you compare fusion with a decompression procedure alone. Again, our campaign against unnecessary fusion, unnecessary instrumentation is far and wide. We published this article last year where otherwise synovial cyst segments undergo fusion. In 30 out of 36 patients, we could just get away with a decompression, and 8 of these patients had a degenerative listhesis. Friends, this scoring system is beautiful. It is holistic in nature because it not only takes the clinical and radiological parameters into purview, but also looks at patients' demands and aspirations, which was not considered earlier at all. There are limitations. It is difficult to do a randomized control study in a private setup that I am in. It is a single surgeon study. We need to do a multicentric study. I would invite my friends to do it with me. Minimal access decompression is technical demanding, especially if you have a severe stenosis such as this, which I did just 2 days back. So the current literature fails to systematically subclassify patients with degenerative listhesis. It's a heterogeneous condition requiring tailor-made treatment for each patient. Decompression has a central place in the management of degenerative listhesis with stenosis, and this particular scoring system is a reliable tool in planning treatment in degenerative spondylolisthesis. I rest my case. Thank you.
Thank you, Dr. Arvind. Again, the paper is open for questions. We have 5 minutes to question Dr. Arvind.
Very rightly you said that one is fusion group, one is decompression group. But in the decompression group, you are telling that minimally invasive decompression surgery. I want to know if we are going in this group, open decompression, what is your say? Will it become unstable because we are opening, or you will advise, you will strict only miss?
No, this is because I do minimal access decompression. If you do any kind of a conservative surgery where you don't strip the interspinous and the supraspinous ligaments, which give you stability in flexion extension, the results should probably be the same. But if you do a wide laminectomy, the rate of progression is about 12.5% compared to the 2.6% that has come up with the minimal access studies.
Well, open surgery, most of we are doing, extensively we are doing. There are only few who is doing minimally microscopic decompression surgery. You say your say, you tell your say, whether we should fuse it or we should come out.
No, if you are doing a conservative decompression wherein you are saving most of the collateral structures, probably you will have a good percentage of patients wherein you can just go ahead and decompress. You will have to perform your own studies.
Dr. Mohan. Yeah.
I have a question for you. Is this scoring system being validated? One. And second thing is, how did you derive at those numbers in the scoring? 1, 0, how did you come to those numbers?
This is an interesting question. So initially, this was more of a unit policy to, get all these factors together. So what we found that back pain has a very important role in judging for fusion, because it's a significant role. Back pain will definitely tilt it towards fusion. So that scored higher compared to others. And when you compare angulation and translation, why 1.5 and 1 for 1.5 angulation, 1 for translation? 1.5 for angulation is because that means there is a void in the front. So translation, it might restabilize over a period of time, but a void in the front is a higher sign of instability compared to a translation.
Arvind, I want to ask you one question, and that is, in degenerative spondylolisthesis that you have, because of instability, there is new bone formation. And therefore, in the lateral recess and in the foraminal, there is a stenosis, where you are going to decompress. And there, you are not going to remove the disc. But actually, the problem is of listhesis, degenerative listhesis, that is causing the problem. So, all these patients who have got a spinal canal stenosis with listhesis, degenerative, have to be fused. Is that what you are trying to say?
No, I'm saying that need not be fused. A large percentage of them who score less than 6 can be just decompressed alone.
Yeah, but subsequent to that, if you don't fuse it, and if you leave the degenerative listhesis alone, there will be movement, and once again they'll form new bone.
That is what we imagine, but that is not what that happens.
But that's what McNabb had said that time in his way back long time
So that's
ago.
what we imagine. Only 2.6% progress, and again they restabilize it. When they restabilize it, doesn't mean they become symptomatic.
But how do they restabilize then?
By throwing more bone. But that doesn't mean that it will cause
But
stenosis.
if they throw bone, new bone, they'll again form restenosis.
That's what we imagine, but they are not symptomatic. I just said that there is no clinico-radiological correlation.
So therefore it requires a long-term follow-up for your patients on this.
Yeah, that would be doing, but most of the kind of follow-up we have, these are all stable situations. The facet is blocking their movement from going ahead. And these are fixed listhesis. You're talking about those which you progress. Probably those which you progress score more than 6, and we need to fuse them.
Dr. Parekh.
Very nice paper, very good documentation, very good over complexification of a very simple subject. Now, two things, like Ramesh Chandra Tiwari said, most people still do open surgery, one. Two is the Christmas tree is not very commonly done now by non-MIS surgeons. Three is if degenerative spondylolisthesis is self-stabilizing, from your slide. 2% of all cases not fused progress. 12% plus.
Dr. Parekh, we have only 15 seconds for his answer, so please.
Yes, sir. If they are going to progress, why do they progress? Because of destabilization on table. So the trick is, do not destabilize. Do a wide laminectomy, do not touch the facet joints, do not touch the pedicles, and do not take out the disc. Just decompress the neural elements, soft tissue and bone.
Absolutely. I agree with you.
Thank you.
Don't the supraspinal
Thank you, Dr. Arvind.
spinous ligament.
Thank you, Dr.
Just do a
Parikh. We
lateral
don't have any more time for the questions.
Please come here to collect your certificate.